Yeah. Just want to try to see how it comes out with the thing on my head instead of always asking someone to record for me. All right. Yes, please.
Using floor prep.
Okay. Mark the incision in line with Langer's lines. Local anesthesia,
Capsule?
please. What's the systolic blood pressure?
83 over.
So give me 200. Okay, you can go up. So right now we're just exsanguinating the limb.
200.
So we just got rid of the blood in the upper extremity, so we have a nice clean field when we operate. Making an incision in line with
728.
that palmar skin crease. Just go through the epidermis and the dermis. Now we're in the subcutaneous tissue layer. And I'm basically just elevating the subcutaneous tissues off the palmar fascia. Self-retainer. So you can see the nice clean white fibers of the palmar fascia, vertically oriented, in line with the incision. And you can see now the fibers are oriented more transversely, hence the name, the transverse carpal ligament. You can see the thenar musculature right here coming off the transverse carpal ligament. As I go deeper, you can clearly see the transverse fibers going this way of this deep transverse carpal ligament. And just deep to that, I'm going to carefully incise it without going deeper than the ligament, because this is the roof of the carpal tunnel. And this is as far distally as I want to go, that fat pad. But I'm carefully going through it, and then you just saw that pop. So I'm just making sure there are no fibers. There's the fat. I do want to continue to release these fibers that are compressing the nerve there too. But there's the nerve, the median nerve right underneath. So these are blunt Metzenbaum scissors. I'm going to basically just identify the plane going up the forearm, and then I'm going to push down on the nerve so I don't injure the nerve as I just free up the tissue and create that plane in the carpal tunnel as well. And then I'm going to take my Metzenbaum scissors and release this ligament, transverse carpal ligament, off the nerve, up the forearm too, just to make sure it's not compressed. And you can see the Metzenbaum tips are pointed ulnarly to prevent any injury to the palmar cutaneous branch of the median nerve that takes off about 5 centimeters proximal to the hand. So I'm pushing down on the nerve so I don't go near it with the tips of my scissors, and I'm just releasing it like that. So it's completely released. And we're done. So now I'm just going to irrigate and close. So as I come back, kidney basin. You just just like to irrigate out the wounds a little bit. Make sure there's no infection. This is what we call a bulb syringe, and we're irrigating with saline. People with carpal tunnel syndrome typically get pain in their hand, numbness, tingling, pins and needles, weakness, loss of grip strength. They often complain that they have to wake up in the middle of the night shaking their hands, sort of like this, for it to wake up again. And they often can drop things when they try to grip or grasp them. Sometimes they'll lose tactile sensation, the ability to distinguish between coins, for instance, in their pockets. But the biggest complaint, the most debilitating complaint, is the numbness and tingling. Their hands are always asleep, especially at night, causing them to wake up. And the thing that goes away almost instantaneously is that latter complaint. Waking up in the middle of the night, having to shake their hands to get the blood flowing through them again. Very rewarding procedure. Patients feel better immediately. The key is to not let it persist for too long, because you don't want to get permanent nerve damage. So right now I'm just closing. I leave the transverse carpal ligament open. I leave the palmar fascia open, and I just close the subcutaneous tissues. There's no pressure on the nerve.